Hi, very good evening. I think we're having some network issues today. Maybe I'm not sure how the quality of video is. So we might possibly have few interruptions in between. I'm not sure though. Right? Yeah, we have some issues with the network connectivity. Hi, very good evening. Am I audible? Like, is it streaming live for you? Hi, Tileli. Hi, Nidhi. Hi, Regina. Tejashri. Hi. Hi, Dipti. Good evening. Hi, Preeti. Mega. Hello. Hi, Ramesh. Okay, right. So we'll move on to the topic for discussion today, right? So I think we're having, my net is comparatively slow. I don't know whether it will be streaming continuously live or not, because the overall quality of video seems to be very low. Okay. Hi Bernice. Hi Jeha, Kumari. Hi Sirisha. Hi Ashok. So a very good evening once again to all of you, right? So today the topic for discussion is, as I mentioned previously, we're going to discuss force distribution and types of tooth movement, right? So the textbook for reference is Proffit, right? So Contemporary Orthodontics by Proffit. So I've even discussed the soft copy of this particular chapter of the topic which we are going to discuss in our group also, right? So before going into the details, right, so we'll just proceed with the overview of the topic which we are going to discuss today, and then we'll go into the discussion pertaining to this very same topic, right? Let me just pan my cam towards the board so that you can have a look. So I guess you can see now, right? So force distribution and types of tooth movement. So this is the overview which we're going to discuss today, right? So as you can see, we're going to discuss on the left side, we're going to discuss about optimum force levels and the magnitude of force and the influence of force on the periodontal ligament. And it's not just the magnitude, but the amount of force that's acting on a particular unit area, that is pressure, right? So we're going to discuss in brief about the optimal force levels, magnitude of force, and the area of periodontal ligament which is being subjected to force, and most importantly periodontal ligament response, right? So which depends further on force per unit area, that is nothing but pressure, right? And also we're going to discuss various values of optimum force levels for orthodontic tooth movement, and also in brief various tooth movements like tipping, translation, rotation, extrusion and intrusion, right? So this particular topic, force distribution and types of tooth movement, is from the chapter Biologic Basis or Biologic Basic of Orthodontic Therapy, right? So you can find that in Proffit. So hope you have a hard copy of the same. It's better if you have a hard copy, right? So this is the overview of the topic which we are going to discuss today. Now let's go into the details and try to find out the relevant information pertaining to the same topic, right? So again, once we complete the topic, right? So once we complete the topic, we'll again pan the cam towards the board so that we can just go through the overview of the topic. Right, so here we go. So once again, a very good evening for all the newcomers or latecomers, I should say. Hi Kalpana, Namrata, Swapnil, Akriti, hi Pritika. A very good evening, right? So hope you're having a hard copy, and also make sure that you simultaneously have notes along with you so that you can make a note of. See, we have a lot many important topics, important points to be discussed in this particular chapter, biologic basis or biologic basis of orthodontic movements, right? So we'll discuss that in brief. So in fact, I've written there as biologic basic. It's not basic, it's basis, biologic basis of orthodontic therapy, right? Yeah, so coming to the topic in specific, effect of force distribution and types of tooth movement, right? So it is apparent that optimum force levels for orthodontic tooth movement should be just high enough to stimulate cellular activity without completely occluding blood vessels in the periodontal ligament. So we'll discuss the influence of force on periodontal ligament. After we conclude this particular topic, right, we'll just have an overview of the entire chapter, and then we'll see what kind of response can we elicit, or what kind of response can we see clinically whenever there is heavy forces acting on a particular tooth, and whenever there is intermittent or persistent light forces acting on it. We'll see all those manifestations and interpretations later, right? So optimum force levels is that which is desired so that there can be increased cellular activity without occluding the blood vessels present in the periodontal ligament. That's very, very important. See, it's not just the amount of force that is important for obtaining a particular tooth movement, but it's also the amount of force that's acting on a particular area of periodontal ligament, right? See, the tooth moves within the bone, and this is possible because the bone resorbs towards the direction of the tooth, and away from the direction there will be apposition of bone, right? So because of resorption, apposition of bone, it's possible to move the tooth within the alveolar bone along with its attachment apparatus, right? So the tooth movement is mainly possible because of periodontal ligament, right? So that's very important. So we need to study in detail the response of periodontal ligament, right? So what kind of activity is happening within the periodontal ligament with increase in force and with duration of force, right? All that we'll discuss very brief later part of the topic, right? So as mentioned here, optimum force levels for orthodontic tooth movement should be just high enough to stimulate cellular activity without completely occluding blood vessels in the periodontal ligament, right? And both the amount of force delivered to the tooth and also the area of periodontal ligament over which that force is distributed are important in determining the biologic effect, right? And the periodontal ligament response is determined not by force alone, but by force per unit area, or that is equivalent to pressure, right? So the PDL response depends not only on the force, but also on the force acting on a particular unit area, that is pressure, right? So just make a note of this particular point, right? So in the process of discussion, we'll be having a few image-based questions also. So I'll be projecting you the image-based questions simultaneously in this live session, right? Yeah, here we go. So if you observe the next paragraph given here, so we have various tooth movements. As you all know, we have this tipping kind of tooth movement, we have this translatory or bodily movement, we have extrusion kind of movement, intrusion kind of movement, etc., right? So let's see what is exactly happening in each kind of tooth movement. So starting with a tipping movement, and this tipping movement is considered as a simplest form of tooth movement, right? So the simplest form of orthodontic movement is tipping. Tipping movements are produced when a single force, for example, a spring extending from a removable appliance, is applied against the crown of a tooth. So let me just show you the image here. So this is, as you can see, it's a removable appliance, right? Holly's appliance which has a spring attached. You can see a finger spring. So these finger springs mainly help in producing tipping movements, right? So this is a finger spring and this is a removable appliance, Holly's appliance, right? So as mentioned here, tipping movements are produced when a single force, example, a spring extending from a removable appliance is applied against the crown of a tooth, right? And in this tipping movement, there is something called as pivoting, right? So assume this as a tooth. When you try to apply force on the crown, right? So there will be movement of tooth along the direction of force At the same time, the root tip moves in opposite direction around a center of resistance. So this center of resistance, or this pivot, we call this as tipping kind of movement, right? So when tipping movement is done, the tooth rotates around its center of resistance, a point which is located about halfway down the root. So the location of center of resistance is around halfway down the root, right? And when the tooth rotates in this fashion, the periodontal ligament is compressed near the root apex on the same side as the spring, and at the crest of alveolar bone on the opposite side from the spring. So this can be understood clearly when you look at this particular diagram, right? So just have a look at this diagram. So this is the direction of force, right? So this is the direction of force, as you can see. So when force is applied in this direction, so obviously the crown moves along the direction of force, right? And as you can see here, so on the same side of direction of application of force, you can see a black area here. This black area represents the compression. I'm really sorry. Yeah. So this black area represents the area of compression of periodontal ligament, right? So we have areas of compression of periodontal ligament in these areas, right? And also that is near the root apex, on the same side where you have applied force, and also on the opposite side near the alveolar crest level, right? So these black areas represent areas of compression within the periodontal ligament, right? Yeah. Now, when the tooth rotates in this fashion as shown in the image, the periodontal ligament is compressed near the root apex on the same side as the spring, and also at the crest of alveolar bone on the opposite side from the spring, right? So you're going to have a question from this particular topic or particular line also. And maximum pressure in the periodontal ligament is created at the alveolar crest and at the root apex. So during tipping movements, just make a note of this point, the maximum amount of force or pressure is created at the root apex, that is on the side of the force application, and also on the opposite side at the level of alveolar crest, right? So that's very, very important. So as a result, progressively less pressure is created as the center of resistance is approached, and there is minimum pressure at that point. So as shown in this image clearly, right? So you can see clearly here that along this apical third, is it clear now? So I'm not sure. Yeah, you can see apical third and at the crestal level. So these are the areas which are away from the center of resistance. Center of resistance is present somewhere here, right? So as we progress or we proceed towards the center of resistance, either from the apical third or from the coronal third, the pressure that is exerted in this area is very much minimal, right? So that's obviously understood. In tipping, only one half of the periodontal ligament area that could be loaded is actually affected. And see, if you observe here, along with this image, they're given you the loading diagrams, right? So these loading diagrams represent the areas where there is pressure. So just remember, in case of tipping movements, if you observe the diagram here, the loading diagram is in triangle shape, right? Half of the triangle. So in tipping, only one half of the periodontal ligament area that could be loaded actually is seen. So as you can see in the image, loading diagram consists of two triangles covering half of the periodontal ligament area. On the other hand, pressure in the two areas where it is concentrated is high in relation to the force applied to the crown. So because of this factor, because we're having more pressure being applied or being generated at the apical third and also at the crestal level, less force has to be applied to the tooth in order to prevent occlusion of blood vessels in the periodontal ligament while performing tipping movements, right? Just keep this in mind, right? So pressure in the two areas, that is in the apical third, that is in tipping kind of movement, the pressure in the apical third and at the crestal level are enormous, right? So in order to prevent any undue negative effects on periodontal ligament, minimal pressure has to be applied. And if at all they ask you the cross-sectional image or the shape of the loading diagram for tipping movements, as you can see in the image, it is triangle in shape, right? So both experiments with animals and clinical experience with humans suggest that tipping forces should not exceed 50 grams. Just make a note of that threshold value, right? So tipping forces should not exceed 50 grams. Right, so this is very easy to understand. So tipping movement, you have movement or pivoting or rotation of tooth around a center of resistance which is located halfway in the root, right, halfway down the root. And during this tipping movement, there can be compression of periodontal ligament either in the apical third on the same side of force application or on the opposite side at the crestal level, which is clearly evident in the image, right? And also the loading diagram shows that the amount of force that's being applied on the periodontal ligament, because of the compression, the loading diagram, the shape is triangular, right? And because of this compression, because of the chances of compression in the apical and crestal third, we should be careful not to apply excess pressure during tipping movements, and the force that is applied should not exceed 50 grams, right? Just make a note of these important points, that would be suffice. Next, if two forces are applied simultaneously to the crown, so this is about only one force being applied on the crown for tipping movement. If at all two forces are applied simultaneously to the crown of a tooth, the tooth can be moved bodily or translated. So that's called as bodily movement or translation. That is, the root apex and the crown move in same direction in same amount. So when the crown and the root move in same direction, so tipping is something like crown moves in one direction, root moves in opposite direction, whereas bodily movement or translated movement is the one where the crown and the root move in same direction in same amount or magnitude as well, right? So that's very important. In case of this bodily movement or translation, the periodontal ligament, see, in case of tipping movement, only apical third and crestal level of periodontal ligament area are subjected to pressure or compression, right? But in case of bodily movement or translatory movement, the entire PDL area or space is being subjected to a lot of pressure, right? So that's the reason why the amount of force that's required in order to produce these bodily or translatory movements are double that of the forces that is required for producing tipping movements, right? If you need X amount of force to produce tipping movement, 2x amount of force is needed to produce bodily movement, right? Because in tipping movement, as mentioned here, only 1/2 of the periodontal ligament is being subjected to compression, that is in the apical third and in the coronal third. Just look at the diagram, it will be clear. But in case of bodily or translatory movement, the entire tooth is being moved, and as a result, the entire periodontal ligament area is being subjected to compression or forces or pressure. So we need the double the amount of force that's needed to produce bodily movement compared to tipping movement. So I hope it's clear, right? And if you observe the values which are given below, we'll just discuss those values in brief, right? So before that, it is apparent that to produce the same pressure in the periodontal ligament and therefore the same biologic response, twice as much force would be required for bodily movement than compared to tipping. Just make a note of this point, right? And to move a tooth so that it is partially tipped and partially, okay, we can neglect that. So if you look at the diagram or table 9.3, where they have discussed the optimum forces for orthodontic tooth movement, just make a note of it, try to memorize them, that's very important. It's not just the values but also the sequence or the amount of force that's needed, from heaviest force needed to produce bodily movement to lightest force that is needed to produce intrusion. So we have this sequence, right? So just make a note of these values, that's very important. So to produce tipping kind of movement, amount of force that is required is 35 to 60 grams, and the amount of force that's required for tipping, rotation and extrusion, right? So you can remember it as TER. So tipping, extrusion, rotation require almost a similar amount of force, that is 35 to 60 grams. Whereas bodily movement, as I mentioned, it is almost double, that is 70 to 120. So the amount of force that is needed to produce bodily movement is highest, 70 to 120 grams. Whereas for root uprighting, it's around 50 to 100 grams. And for intrusion, it is the least, that is 10 to 20 grams, right? Just make a note of these points and you can write down from the ascending order to the descending order. So the highest amount of force that's required to produce bodily movement is around 70 to 120, whereas the least amount of force that's required is for intrusion, which is around 10 to 20, right? For tipping, Rotation and extrusion, it's around 35 to 60, and for root uprighting it's in the range of 50 to 100. So that's very important. Make a note of these values and try to memorize them, as well as the order, ascending or descending order, based on the amount of force required for a particular orthodontic tooth movement. Right? I hope it's clear. I mean, you have any confusion or you need much clarity or any topic or any specific point, you can just make a note of it in the comment. We'll just try to elaborate on the same, right? So let me just check out the comments. You mean to say it's not going live? Yeah, it's showing actually as poor connection, as I mentioned previously. Hi Pooja, Rana, Satish, Farjana, Pooja, Neetu, Renu. Yeah, it's streaming. Please give me some clarity, because for me it is streaming here. I mean, I have another device. It is streaming here live for me. I mean, like I have some network issues, as I mentioned previously. I mean, is it streaming live for you? I mean, if at all it is streaming live, just give me a thumbs up sign. Okay. Okay. Okay, in case if anyone missed what I have discussed in the past 10 or 15 minutes, maybe once the recorded version is available on YouTube, you can just go through the following minutes, right? Yeah, I think I can proceed. So far we have discussed about the tipping movement, the optimum amount of force, and the changes which we can see in periodontal ligament, and also we have seen about tipping and also bodily movement or translatory movement, right? Yeah. Thank you. Thanks for your feedback. And yes, Tileli, yeah, bodily movement can be produced only when the direction of force is acting along the center of resistance. That's very much true. Only then we can produce bodily movement. But in fact, clinically, it can be quite impossible. So there is always a combination of tipping as well as bodily movement. Anyways, we'll just proceed with the next kind of movements, right? Rotation, intrusion, as well as extrusion. Sure. So in theory, forces to produce rotation of tooth around its long axis could be much larger than those to produce other tooth movements, since the force could be distributed over entire periodontal ligament rather than over a narrow vertical strip. In fact, however, it is essentially impossible to apply a rotational force so that tooth does not always tip in its socket, and when this happens, an area of compression is created, just as in case of tipping movement, and for this reason appropriate forces of rotation are similar to those of tipping. So it's very clearly mentioned here that, see, rotation, theoretically, if you assume that rotation is we have to move the tooth within the socket, we have to move the tooth within the socket. As a result, lot of force is needed in order to move the tooth, because we have periodontal ligament three-dimensionally, isn't it? But practically speaking, that's not the issue, because practically, as mentioned here, it's not possible to produce pure rotation movements, right? So there will be some amount of tipping simultaneously during rotation also. As a result of tipping, as we discussed previously, there can be again areas of compression, right? So keeping that in mind, we need to reduce the amount of force that's required to produce rotation or rotary kind of movement, right? Hope it's clear. So pure rotation movement, theoretically, yes, we need lot of force, I mean, in order to produce this kind of rotation. But the problem here is, if you apply a lot of force, then along with rotation, clinically, there is even tipping movement that is seen, right? So it's not practically possible to produce pure rotation. So along with rotation, there will be some kind of tipping, right? So because of tipping, again, there can be areas of compression. So to overcome that, we're applying forces which are almost similar to that of tipping. As I mentioned in the table, it's given that for tipping, for extrusion, and for rotation, the type of movement or the amount of force that's required is almost the same, right? So just make a note of it. So even for rotation, the amount of force should be almost equal to that of tipping only, right? And now coming to extrusion and intrusion, of tooth movements, right? Extrusion and intrusion, right? So extrusion movements ideally would produce no areas of compression within the periodontal ligament. So extrusion, there is only tension, right? So there is no compression of periodontal ligament. Like rotation, this probably is a more theoretic than practically possible, since if the tooth tipped at all while being extruded, areas of compression would be created. Even if compressed areas could be avoided, okay, that's fine. Yeah, that's what he's saying. So even pure extrusion movement is not practically feasible. So along with extrusion, there can be some kind of tipping, which again can lead to this kind of compression, right? So as a result, for tipping or for rotation or for extrusion, the amount of force that's applied is almost the same. So we're having a justification why we're having almost equal amount of forces for tipping, extrusion and rotation, TER, right? You can remember that as TER or RET, any mnemonic based on your convenience. Now, coming to intrusion. For many years, it was considered essentially impossible to produce orthodontic intrusion of teeth, but now clinically we are able to achieve this kind of intrusion with various devices. However, light forces are required for intrusion because the force is concentrated over a very small area, especially at the root apex, right? So while we are trying to intrude, the amount of force that's being concentrated is almost at the apical third of the periodontal ligament area. As with extrusion, a tooth probably will tip somewhat as it is intruded, but the loading diagram nevertheless will show high force concentration at the apex. Only if the force is kept very light can intrusion be expected. So as a result, to prevent more force accumulation or pressure accumulation in the apical third of the C, as I said, during intrusion, lot of force or pressure is being focused or concentrated at the apical third of the periodontal ligament, right? So to overcome that, we need to apply very, very light forces. That's what is mentioned here, right? So that's the reason why we're having least amount of force that is needed in order to produce this kind of intrusive movement, right? Yeah. So you have clarity over what we have been discussing so far. It's very simple to understand. It's purely mechanics, right? It's purely mechanics, right? So the force distribution, effects of force distribution and types of tooth movement. So force distribution, it should be within the optimum range. Just keep that one point in mind. The force that you are applying or we are applying on tooth during orthodontic tooth movement has to be at optimal level, or else what happens if it exceeds beyond the optimum? There can be occlusion of periodontal ligament, there can be hyalinization, there can be necrosis, lot many manifestations which we'll discuss again later. So keeping that in mind, we should put force to minimum, understanding the mechanics, understanding the physiology of periodontal ligament. As mentioned, tipping is the simplest kind of movement. Tipping is nothing but pivoting around the center of resistance, right? So assume this as a tooth, we have a pivot. So around the center of resistance, the direction of movement of crown and root are in opposite direction, and the amount of force that's required is around 35 to 60 grams, right, as mentioned here. And if two forces act along the center of resistance, as one of our aspirants clearly rightly mentioned, then there will be bodily translation where the crown and root move in the same direction in same amount, right? And the amount of force that's required to produce this bodily movement is double that is required to produce tipping movement. And the loading diagrams, just make a note of it. It's mentioned in the diagrams also. You can just look at the diagrams, it will be very clear for you, right? So loading diagrams, they're triangular in shape in case of tipping, they are rectangle in shape in case of translation. As you can see here, these are the loading diagrams. Is it clear? Yeah, you can see this is a tipping kind of movement where you can see triangle shaped black lines, right? Black shaded areas which is triangular. So that is a loading diagram for tipping. And for translation, you have, as you can see, when you're trying to translate, you can see the entire area of PDL is being subjected to compression. So the loading diagram is rectangle in case of translatory movement, right? That's very important. You can just make a note of these points as well, right? And in case of rotation, in case of extrusion, we have seen why the amount of force is equivalent to that is required for tipping, right? So we have discussed all that It's very simple. And then intrusion, since the force is being focused or concentrated in the apical third, the pressure, we should not call force, because it's not the force, it's force acting per unit area that leads to compression, right? So it's a pressure accumulation during intrusion at the apical third. As a result, light forces have to be delivered. And if you look at the table 9.3, where they have discussed optimum forces for orthodontic tooth movement, and I'll just summarize this. It's highest for bodily movement or translation around 70 to 120. It is least for intrusion around 10 to 20. And then it is second least for tipping, rotation and extrusion around 35 to 60 grams. And root uprighting, it is second highest around 50 to 100. So if you go from least to maximum, start with intrusion, then tipping, rotation, extrusion, followed by root uprighting, followed by bodily movement or translation, right? Hope it's clear. So now this completes the topic effects of force distribution and type of tooth movement. Now we have many important points to cover. Just the important points. I'll just summarize the important points. You can make a note of these points from the chapter, the biologic basis or the biological basis of orthodontic therapy, right? So before that, we'll just have a 2-minute break. In the meantime, I'll just go through the comments here. I mean, is it streaming live now? Are you having any issues with the streaming still? No problem, it is streaming live. Okay. Did I miss any comments previously? Okay. Hi viral videos. Good evening. Shweta, unbelievable that I'm seeing you live. Great work for dentistry, sir. All the very best. Thank you, Shweta. Thank you for your wonderful wishes. Nidhi, which group of principal fibers of periodontal resist tipping movements in orthodontic treatment? Circular fibers, it is for rotation. Tipping movements, I assume it has to be oblique group of fibers. I think we discussed this already previously also. Yeah, different types of periodontal ligament fibers and what kind of movements they resist. I assume we have discussed this in one of the live sessions also. Anyways, I'll just cross check it once again. I'll try to get the answer accurately, right? So we have different groups of fibers resisting different types of movement. It's given clearly in Orbans also. I remember referring Orbans for this particular thing. Anyways, I'll just again post the same once the video is uploaded, right, Nidhi? Yeah. Hi Sirish Chandra, you're from Nepal. Hi, glad to hear from you. Hello. Mega Jain, how can we assess where is the center of resistance? Obviously, center of resistance depends upon the mass, and it is clinically, I mean, it's evaluated based on many animal studies and human studies, and literature tells us that center of resistance in case of a tooth is present halfway down the root, as mentioned here in the textbook also. Right, Mega? Regina, this is not from Balaji. We have clearly mentioned it in our post also. We are referring contemporary orthodontics Proffit. William R. Proffit. Anyways, you need not worry. Once the session is complete, it will be uploaded onto YouTube. You can just go through the entire video, if at all, in case you missed anything. Root torque? As such, I haven't heard of such term. Torquing is rotary kind of movement. I mean, have you heard of it, or did you come across anywhere like the term root torque Farzana? I mean, what is the context? Anyways, I'm just making a note of it. We'll see what I can find out from my references. Bernice, okay, live. Okay, Bernice. Nidhi, okay. Hi, Abhishek. Yeah, we had different groups of fibers, alveolar, crest group of fibers, horizontal, oblique. Anyways, each group of fibers has its own function. However, most of the functions do overlap. Anyways, I'll just refer that and I'll let you know again. Yeah, we have, I think I missed another comment. Yeah, what is the difference between tipping and root uprighting? Tipping, I mean, as such, it is pure pivot movement, right? So the crown moves in one direction, whereas root in opposite direction, right? Along the pivot, there is movement. But root uprighting is, I think it's a combination of tipping as well as translatory. I'm not sure. Anyways, I'll just refer this also, because mostly our root uprighting is done for mesially tilted molars, or whenever there is a loss of tooth, a permanent tooth, the adjacent tooth drifts into that space, right? Either distally or mesially, depending upon the edentulous area. So in such cases, we advise this root uprighting. Anyways, I'll try to refer this again and I'll see what the exact difference is between tipping and root uprighting. By the way, I'll just post all the answers in the comments below once the video is uploaded, right? Yes, Bernice, we had discussed this in oral histology. Okay, alveolar, crest group and oblique are responsible for tilting. Okay. Yeah, thanks, Bernice. Arjit, you said torque is movement of root. Okay, you mean to say tipping. Okay, root movement alone is root torque, resisting the crown movement. How is it possible? Then there has to be bending of root. Anyways, I am not aware of this rule, of this term root torquing. I'll let you know soon, right? So anything else? Okay, along with that, I have gone through the entire chapter and I found few important points, right? We'll just have a discussion. I'll just briefly read out all these important points and see that you make a note of these points, right? So the biological basis of orthodontic therapy. So in that chapter, if you see, the basic principle or orthodontic treatment is based on the principle that if prolonged pressure is applied to a tooth movement will occur as the bone around the tooth remodels. As we discussed previously, there will be resorption and there will be apposition of bone. In essence, the tooth moves through the bone carrying its attachment apparatus with it as the socket of tooth migrates. And this is very important because the bony response is mediated by the periodontal ligament. tooth movement is primarily a periodontal ligament phenomenon, right? So I'll just repeat the same. Because the bony response is mediated by the periodontal ligament, tooth movement is primarily a periodontal ligament phenomenon, right? You can just make a note of this point. And under normal circumstances, the periodontal ligament occupies a space approximately 0.5 mm in width around all parts of the root. So in other words, the width of PDL space is around 0.5 mm. You can just make a note of that point also, right? And in periodontal ligament, we have two categories of elements, like we have cellular elements and also we have this tissue fluid, right? So cellular elements mainly contain undifferentiated mesenchymal cells, which include fibroblasts as well as osteoblasts. PDL is not highly vascular. It does contain, however, even though we just can't say PDL is avascular, cementum is avascular, PDL is slightly vascular. It contains blood vessels and cells from vascular system. Nerve endings are also found within the ligament. Both the unmyelinated nerve endings associated with perception of pain, complex receptors associated with pressure and positional information or proprioception. This is very important because see, we usually when we discuss pulpal pain or periodontal pain, we say pulpal pain is poorly localized, whereas periodontal pain can be localized very well. It's because pulpal pain, it's represented poorly in the sensory cortex, and periodontal pain, once the infection reaches the periodontal ligament, right, we have these receptors, proprioceptors. Proprioceptors are nothing but, for example, if I am raising my hand and I'm holding my hand at this level, how do I know that my hand is at a particular level? I mean, I can appreciate that my hand is at a particular level, right? So this ability to appreciate the position or to have the appreciation towards the position sense is called as proprioception, right? So we have receptors for pain. We have these unmyelinated nerve endings for pain. We have these receptors which perceive pressure as well as proprioception in the periodontal ligament. Make a note of this. This is very important. And as I said, periodontal ligament contains cellular elements and also tissue fluid, right? So it acts as a shock absorber, right? It acts as a shock absorber when there are forces acting on a tooth. Now, again, we have certain physiologic manifestations when pressure or force is applied on a tooth, right? If you observe table 9.1 and 9.2, is it 9.2? Yeah, table 9.1 and 9.2, they have clearly shown what happens physiologically within the periodontal ligament when there is heavy pressure and when there is sustained pressure. They have given that very well based on different timings. If you observe table 9.1, physiologic response to heavy pressure against a tooth. When the heavy pressure acts on a tooth for less than 1 second, periodontal ligament fluid is incompressible. Alveolar bone bends, piezoelectric signal is generated. If the duration of this heavy force acting is for 1 to 2 seconds, PDL fluid is expressed out, tooth moves within the PDL space. We have this 0.5 mm space, right? And when this heavy force acts for 3 to 5 seconds, PDL liquid is squeezed out, tissue is compressed, and there is immediate pain if the pressure is too heavy. So these are the clinical manifestations of physiologic changes that we can expect when heavy forces act for 1 second, less than 1 second, 1 to 2 seconds, and 3 to 5 seconds, right? And also we have another table, physiologic response in sustained pressure against a tooth, where they have given the duration as discussed now. And in this entire table, if you observe after 4 hours, when sustained pressure is applied for a minimum of 4 hours, there is increased cyclic AMP levels. So these cyclic AMP levels, they have a significant role, which we'll discuss next in the next subsequent section, right? So just go through the tables, they're very important. Now, as I said, bone bends. The bone has this property of bending. Whenever heavy forces act upon a tooth, they get from the tooth, they go into the periodontal ligament, which is shock absorber, and from there it is translated into the bone. As a result, there is bending of bone, right? So upon wide opening of the mouth, the distance between mandibular molars decreases by 2 to 3 mm. It's because the body of mandible bends as the mouth is opened and closed even without heavy mastication loads, right? So this shows that there is bending of a bone possible, leading to decrease in space between the posterior teeth as well. Now, coming to role of periodontal ligament in eruption and stabilization of teeth. They have given a beautiful diagram here in 9.2 where they have clearly shown the amount of force that is acting on the teeth. It's from the soft tissues, as you can see here. So we have lip musculature here and we have tongue, right? So we have tongue acting on from the palatal side or from the lingual side, and the lip musculature on the labial aspect or on the buccal aspect. As you can see, the amount of force that is acting or the amount of force that is exerted by the lip, it is 5 grams in case of upper tooth as well as lower tooth, whereas tongue exerts less than 5 grams in case of upper tooth and around 10 grams in case of lower tooth. So tongue has greater force exertion on the lower teeth, right? So it means that the forces which are acting, see, from the musculature we have these soft tissues, lip on the buccal side or on the labial aspect, and on the lingual aspect we have this tongue, right? So it clearly shows that the amount of forces that are acting on either side, they are not balanced. They are not balanced. However, the stability of the teeth is being maintained because of the periodontal ligament, right? So the periodontal ligament metabolic activity is responsible for maintaining the tooth in its position even though there are unbalanced forces on labial aspect as well as on the lingual aspect. And the force magnitude they have given here clearly, and of course we can expect a question from this area also, right? So from lip, the amount of force that's acting is 5 grams. From tongue, the amount of force that is being exerted on the upper teeth is less than 5 grams. On lower tooth, it's around 10 grams, right? Now, periodontal ligament and bone responds to sustained orthodontic force. See, whenever there are heavy forces acting on a tooth, there is rapidly developing pain, necrosis of cellular elements within the periodontal ligament, and there is undermining resorption of alveolar bone near the affected tooth. So whenever there are heavier forces, these are the manifestations which we see. Obviously there is going to be a lot of pain, and there is also, as I mentioned previously, hyalinization, necrosis of cellular elements within the PDL, and something called as undermining resorption, which is not at all favorable. Whereas when light forces are applied, then what happens is there is survival of cells, viability of cells being maintained. As we discussed, we have this optimum force levels, right, to maintain the viability of the PDL cells. So when light forces are compatible with survival of cells within the PDL and a remodeling of tooth socket by relatively painless frontal resorption. So heavier forces we have undermining resorption, which is not favorable, and lighter forces we have this frontal resorption, right? In orthodontic practice, this is very important. The objective is to produce tooth movement as much as possible by frontal resorption. Just make a note of it, right? And then biologic control of tooth movement. Tooth movement is possible because of biologic electricity or piezoelectricity, and also because of pressure tension in the periodontal ligament that affects blood flow. These are the two theories. From a contemporary perspective, it appears that both mechanisms may play a part in biologic control of tooth movement, right? And just make a note of it. Effects of force magnitude. If a removable appliance is worn less than 4 to 6 hours every day, it will produce no orthodontic effects, right? So for a removable appliance to exert orthodontic movement, orthodontic tooth movement, it has to be worn for more than 4 to 6 hours every day. So this is the threshold limit, or this is the threshold value. Again, I'll repeat the same sentence. If a removable appliance is worn less than 4 to 6 hours per day, it will produce no orthodontic effects. Above this duration threshold, tooth movement does occur. Just make a note of it. This is a threshold value for the duration for which a removable appliance has to be worn in order to produce some desirable orthodontic tooth movement, right? Yeah. And as I mentioned previously, when sustained pressures are applied for more than 4 hours, I said there is rise in cyclic AMP levels, right? So these cyclic nucleotide levels in the periodontal ligament, they are second messengers which are needed to stimulate cellular differentiation, which makes it possible for resorption to happen and for bodily movement or for movement of tooth within the alveolar bone, right? So this is possible because of this secondary messengers, that is cyclic nucleotides or cyclic AMP, right? And we have different types of forces acting on the tooth. We have a continuous force, we have interrupted force, and also we have intermittent force. If you can observe figure 9.13, figure 9.13, as you can see here, right? So here you can see, so this is the first appointment. This is during reactive, that is during the second appointment. I mean, you can call this as first, second, third appointment. So this drop represents appointments, right? So in fact, in case of continuous force, we can see almost the force is, even though there is a variation in force, see, the force seems to be decreasing. Even then, during reactivation, during the appointment times, the force reaches to maximum level or to the original level, right? So this kind of force, we call it as continuous force, right? And here you can see interrupted force. Interrupted force is the one where there is interruption and the force becomes almost zero. You can see here force is becoming zero. That's why it's called as interrupted, right? Whereas this is continuous, where you will not see a zero drop. But here in interrupted, we have this zero drop, right, during appointments, right? And then we have this intermittent. Intermittent can be interrupted. See, intermittent is just the best example for intermittent is a removable appliance. When you wear a Hollis appliance or any removable appliance, there will be force acting. And again, when you remove, the amount of force acting on the tooth decreases. And again, when you wear the removable appliance, the force acting on the tooth again increases, right? So that is intermittent. So you are having intermittent forces, right? Whereas continuous force and interrupted forces are completely different. So we need to understand the differences between these forces also. I'll just go through the theory now. Continuous force is that the force that is maintained at some appreciable fraction of the original from one patient visit to the next. So even though we will not have the same magnitude of force throughout the entire treatment procedure, we can have at least appreciable fraction to the original. If the original force is 10x, then the force can drop to 7x or 6x or 5x for that matter, but it will not drop to 0. So that's an example for continuous force. Interrupted force, the force levels decline to 0 between activations or between appointments, right, as we have seen in the image, figure 9.13. And intermittent forces level decline abruptly to 0 intermittently when the orthodontic appliance is removed by the patient, or perhaps when the fixed appliance is temporarily deactivated. So as I said, we have this removable appliance, Hollis appliance, or any removable appliance with a finger spring. You wear it, the force acts. You remove the force, again, you remove the appliance, the force drops to 0. And again, when you place the appliance back into the mouth, the force again restores, right? So this is intermittent. Forces acting intermittently, right? So these are the differences between continuous, interrupted, and intermittent. And finally, we have another important factor, that is the effect of drug on orthodontic tooth movement. And I've seen a couple of questions from this topic also. So what are the drugs that increase orthodontic tooth movement or that promote orthodontic tooth movement, and the drugs which inhibit or decrease orthodontic tooth movement? We'll just have a look at briefly the drugs which are responsible for these movements. Under some circumstances, vitamin D administration can enhance the response to orthodontic force. And also, direct injection of prostaglandin into the periodontal ligament has been shown to increase the rate of tooth movement. However, it's not clinically viable because that injection is very painful. So, vitamin D and prostaglandin injection accelerates or promotes orthodontic tooth movement, right? Just make a note of it. Vitamin D as well as prostaglandins. So an inhibitor of prostaglandin obviously discourages or inhibits or tries to decrease the rate of orthodontic tooth movement. So we have various prostaglandin inhibitors, like we have this NSAIDs, right? Now, bisphosphonates, osteoporosis, used in treatment of osteoporosis, and prostaglandin inhibitors, which are used for treatment of arthritis. These are the two types of drugs that depress the response to orthodontic force, as we discussed now, right? So the drugs which promote rate of orthodontic tooth movement are vitamin D and prostaglandin, and those which inhibit or decrease the rate include bisphosphonates as well as prostaglandin inhibitors, right? So we have various drugs that affect prostaglandin activity, like you have corticosteroids, you have NSAIDs, right? And also miscellaneous drugs. Several other classes of drugs can affect prostaglandin levels and therefore could affect the response to orthodontic force. So not only NSAIDs or corticosteroids, but also we have other drugs which affect prostaglandin levels, which include tricyclic antidepressants, example amitriptyline, imipramine, and various anti-arrhythmic drugs like procaine, anti-malarial drugs like quinine, chlorquinine, and methylxanthines, and also anticonvulsant drugs like phenytoin have been reported to decrease tooth movement in animals, and some tetracyclines inhibit osteoclast recruitment, affecting the tooth movement similar to that of bisphosphonates, right? So just remember these classes of drugs: tricyclic antidepressants, anti-arrhythmic drugs, anti-malarial drugs, methylxanthine drugs, and also anticonvulsant drugs like phenytoin and even tetracyclines are known to decrease the rate of tooth movement, right? So these are the influence of drugs on tooth movement, right? So we have drugs which promote tooth movement, and also we have drugs that inhibit or discourage tooth movement, orthodontic tooth movement, right? So this is the biologic basis of orthodontic therapy. Few key points which I found to be very much important, right? So you can just make a note of these points, revise, and I hope this will be very much useful and relevant for you during your preparation as well, right? Torquing is nothing but forces acting in opposite direction, which would obviously produce a rotary kind of or rotation kind of momentum shape, right? Yes, Dr. Arjit, by 2-point contact, that's true. Thank you. Okay, Preeti, you say her referred Orban's? Good. Orban says horizontal fibers and apical crest fibers resist tipping. Okay. Okay. I was assuming oblique fibers. Anyways, as you said. Anyways, I'll also refer Orban's, right? Thank you so much, Preeti. I mean, if possible, Preeti, can you share other group of fibers also, like what kind of movements do they resist? So as you say, horizontal fibers and apical fibers, they resist tipping kind of movement. Excellent. I mean, if possible, can you share other group of fibers also? Hari Krishna. Yeah, Hari, I have seen your mail. Yeah, definitely I'll reply. I mean, previously also I think you sent me one mail, right? I think I replied to that also. Anyways, I'll just go through your mail once again. I'll reply. Yeah. So, any other queries, right? If you have any other queries, you can post them here. What kind of analgesic should be given for pain in ortho patients? A very good question. So obviously, as we discussed, right? So NSAIDs can decrease the rate of movement, right? So obviously, we can go for a mild analgesic, a weak analgesic, starting with paracetamol, or steroids also will not indicate. But see, as per theory, they have the potential to inhibit, right? I mean, they have the potential to decrease the rate, but as such, clinically, I'm quite sure they're not going to have drastic effect on tooth movement. I mean, even I have undergone orthodontic treatment and I have taken a couple of painkillers. Even my orthodontist prescribed me a few painkillers also. So theoretically, there is a potential for these NSAIDs or a PGI inhibitor agents to decrease the rate of orthodontic tooth movement, right? but clinical I don't think will have such drastic effects on tooth movement. Anyways, that's a good question. So ibuprofen, aspirin, yeah, they are good alternatives. Okay, anyways, I'll just try to focus and see if we can find any specific information on analgesics to be given for orthodontic patients. Yeah, yes, Bernice, obviously that's what I'm trying to say is, yeah, clinically we might not find such effects, right? So occasional intake, as you said, okay. Anyways, we'll try to have some proper reference also. Prithvi, it's a very good question. So pain management in orthodontic patients, right? So anything else? Okay, it's given in Proffit, ibuprofen and aspirin. Okay. Okay, Nidhi, thank you. Anyways, paracetamol is not going to work, right? Poor analgesic. Yeah, aspirin has side effects, but again, once in a while it will not be an issue. Pooja, your question is incomplete. Can you just complete your question? Difference between? Yeah, Preeti, you have an answer. Alveolar crest prevent intrusion, extrusion and rotational movement. So here you go, friends. So horizontal fibers and apical fibers resist tipping movement. Alveolar crest fibers resist intrusion, extrusion and rotational movement. Okay. Okay, you mean to say page 343. Okay. Anyways, I'll refer that again. Thanks, Nidhi. Thanks for giving me the reference. So Alveolar crest, you said, Preeti, oblique fibers, vertical, okay, intrusion movements, okay, fine. Yeah, horizontal fibers occupy 1/4 of perial space. Pooja, interrupted is, yeah, I thought like you would have a doubt. So interrupted is the force falls to 0, right? For example, you have gone, I have gone to a dentist for orthodontic treatment. They have placed some fixed appliance, right? So the force is maximum. So by the time I go to the orthodontist in the next appointment, the force falls to 0. And again, the orthodontist, my orthodontist will reactivate and try to increase the force levels, right? So that is interrupted. Interrupted in the sense I'm having maximum force, it falls to 0, and then when reactivated, then the force level again rises. So that is interrupted. Intermittent is something where the force acts for some period of time, in between appointments itself. It has nothing to do with appointments. For example, if I'm having a removable appliance, I put that appliance, maximum force acts on it. I remove the appliance, the force becomes 0, right? So that is intermittent. You're trying to deliver forces intermittently, right? So that's the difference between interrupted and intermittent. So intermittent also includes interrupted forces. That's what is mentioned in the literature, right? I hope it's clear. Nidhi, you mean to suggest a para before what I was discussing? Okay. Yeah. Excellent, Nidhi. Thank you. See, as you can see here, as Nidhi rightly mentioned, page 343, it's mentioned here that both children and adults on chronic steroid therapy, both children and adults on chronic steroid therapy may be encountered, and possibility of a difficult tooth movement in these patients must be kept in mind. The fact that analgesics often are prostaglandin inhibitors raises the interesting possibility that medication used by many patients to control pain after orthodontic appointments could interfere with tooth movement. Fortunately, although potent prostaglandin inhibitors like indomethacin can inhibit tooth movement, the common analgesics seem to have little or no inhibiting effect on tooth movements at dose levels used for orthodontic patients. So here you have the answer, Prithvi, and thanks Nidhi for the reference. So the analgesics which we are using, prostaglandin inhibitors which are using at the therapeutic level in our dentistry pain relief, they have little or no effect on orthodontic tooth movement, except for few drugs which are used long term, as Pernis rightly pointed out. When they are used for long term, as in case of you have this treatment of osteoporosis, if I am not wrong. I was just going through that. Yeah. In treatment of arthritis, we use these NSAIDs long duration, right? So elderly patients do use them, right? So except in such cases, usually for shorter duration and at low doses which we are prescribing in our profession, will have little or no influence as given by the standard textbook reference, right? Hope it's clear. Yeah. Role of fibers. Okay, before that, yeah, Prithvi, you say, please explain the role of fibers in tooth movement in detail. Yeah, that's what we have. I mean, Preeti has given us the reference, right? So oblique fibers, you mean to say the role of fibers in tooth movement? Okay, you mean to say the mechanism of tooth movement per se? Fibers have nothing to do with this. I mean, periodontal ligament as such, as mentioned here, the metabolic activity within the periodontal ligament, as I mentioned, cyclic AMP levels and all, they have the role in cellular differentiation, osteoblast regeneration, or osteoclast formation, promotion, etc. Right? So these fibers, actually, as mentioned by Preeti, they have some role in preventing certain kind of movements, but as such, tooth movement is greatly influenced by the metabolic activity, as mentioned here, which plays a key role in affecting this resorption, right? So because of this frontal resorption or undermining resorption, we have this tooth movement possible. Yeah, anything else? I mean, is it clear, Preeti, or you have anything specific to find to know? Yeah, for your question, I think Preeti has given the answer. Role of fibers in tooth movement, actually, so obviously the fibers which resist different kinds of movement were discussed by Preeti here itself. Yeah. And that's what he's saying. And also regarding mechanism, they said that if the tooth is moving towards this direction, the periodontal ligament which is present here, that gets compressed, the blood vessels get compressed, there will be necrosis, again there will be resorption that facilitates movement of tooth, right? And on the opposite side there will be apposition. Yes, exactly, Preeti. PDL fibers, they resist the movements which you mentioned. Yeah, good. So anyways, it's really great to see most of you actively involving in the discussion, and along with standard references. It's really great to have you all live. So I feel satisfied. So this gives me ultimate satisfaction. It's not just one person talking. It's about when you have this kind of live interaction happening. So it's like win-win situation. So the flow of information is two-way, isn't it? Yeah, so you have any further questions, I'll be happy to answer. So although as such, I mean, I'm not sure how many of you referred Proffit in your undergraduation. Even I followed Balaji, but during my PG prep I had to refer few topics, right? But the standard given here is excellent, just quite excellent. And I was having this particular doubt regarding edgewise appliance and beg appliance. I always had this confusion, like what is edgewise, what is beg appliance and all. And when I referred Proffit today, while preparing for multiple choice questions for tomorrow's discussion, it's given very clearly in Proffit, like what exactly is edgewise appliance, what exactly is beg appliance, and how Angle, the father of modern orthodontics, has designed all these appliances, starting from E-wire, you have this pin and tube appliance, and then you have this arch wire, and then you have this edgewise appliance, and now the entire modern orthodontics is based on the foundation laid upon by Angle itself. So he has started this concept of edgewise, and from there we have various contemporary designs of edgewise appliance, and latest we have this beg appliance. Even beg appliance we have certain modifications, right? So all these things are given very clearly in your standard textbook like Proffit. If at all you have plenty of time, if you're not, I mean, if in case you are an undergraduate student, it's a perfect time for you to go through Proffit, understand the concepts, and also Molars, right? Also I discussed in one of the YouTube videos. You have this weekly schedule where I have given you the standard textbook references also. Proffit, Molars, Handbook of Orthodontics, etc. Right? Just go through these standard textbooks. The concepts are very clear. You feel really enthused and you'll start loving the subject. So prosthodontics, orthodontics, it's all about mechanics. It's all about understanding the basic physiology and anatomy of how your system is working, and that really gives you a different perspective altogether. It's not just mechanical, right? It's something which is beautiful. Subject is really, really beautiful, isn't it? Yeah. Welcome Viral, Farjana, you're welcome. Nidhi, you say bingo? Bingo chips, you mean to say? Okay, bingo. Jeha, you mean to say it's great? Okay, fine, okay. Prithvi, sir, it's great to have a teacher like you. Thank you. Can you please do more textbook live discussions? Of course, Prithvi, I would love to do these textbook live discussions. In fact, of all the sessions we have, this is my personal favorite. Along with this, the Saturday's live session. Wednesday and Saturday, my favorite live sessions. But because of time constraints or other commitments, I'm unable to really promise you that I can do more and more textbook discussions now. But at least 2 months prior or 1.5 months prior, I will definitely come with more and more live sessions, definitely, right? So we have one regular schedule going on. We'll be completing that in 2 weeks. Once I complete that, I'll be having plenty of time, in the sense I can spend more time with you people on live sessions as well, right? So definitely we'll have more textbook discussions, right? And thank you for your wonderful motivating comment, right? Thumbs up. Bernice, okay Bernice. Bernice, I've been waiting for weekly schedule for oral path. I'm sorry Bernice, as of now this week, I think it's already Wednesday. We have 3 more days. So I don't think it will be useful even though if I present that weekly schedule now. But from next week, right, so we have the schedule, right, we have 2 subjects or 3 subjects in our comprehensive batch. We'll definitely have weekly schedules for rest of the subjects also. We actually, the problem is, Bernice, when we started this project in Jan, we didn't think of doing weekly schedules then. But later, when I assumed that I was preparing, so I just realized the importance of weekly schedule, and then altogether we started making these weekly schedules when we were almost halfway through our course. So that's the reason why we have weekly schedules only for 12 subjects. So maybe for other 12 or 13 subjects, definitely I will make weekly schedules, and most probably next week, at least from next week onwards, next Sunday, Monday onwards, you'll have weekly schedules for all the subjects, right, except oral path, right? Just give this consideration. We'll definitely do for other subjects for sure. Hi Sadhana, we're about to conclude our session and you just come. Hi. And it's really a very great feeling that all of you, like who are coming to live sessions, have joined my comprehensive batch, and I really feel proud and really so happy and satisfied to have you all on my platform. And definitely we'll do our best, and we'll try to give as much information as quality as possible. And also we'll definitely have, I mean, any case, if in case you have any difficulty in following the schedule, or any difficulty during which you are facing during a course of preparation, you can mail me 24/7. And we're starting this concept of study clubs. We're going to have discussions from Friday onwards, right? You can make most use of them, and if in case you have any queries, any doubts, any apprehensions, or any suggestions, or for any motivation, you can mail me at proudtobedentist@gmail.com. I would be happy to help you, right? Regina Maurya, you say live discussions are very helpful. I always was scared of these topics till now. Thank you. Yes, that's true. We are scared of these topics. We're all scared of these topics, but once you start going through them, once you start understanding these topics, you'll start enjoying them. That's for sure, right? So that's why when you have a fear towards anything, when you start approaching that, you lose that fear, obviously. That's the rule of nature, isn't it? Nidhi, yeah, important topics for medical subjects, definitely Nidhi. You can just refer our playlist. We have few subjects covered. I think mostly clinicals, I reckon. Definitely, we'll be covering medical subjects also. Important topics as well as the weekly schedules. Okay, Sadhana, you just got free from work. Good. Anyways, glad that you joined us live. Yeah. Viral videos. Are you giving live sessions from different place? A different place in the sense, I mean, I'm at my own place. I mean, the place where I record my videos, that's the same place where I'm giving you the live sessions also. Sometimes I go to a different place, my hometown, and even from there I do make some live sessions, especially those live sessions which have orange background, right? So that's my hometown. Prithvi, sir, can you please do video of all subjects like you have uploaded in general medicine of important topics? Yes, Prithvi, we have important topics, like we covered around 11 to 12 subjects. You just go through my channel, just go through the playlists. You have in playlist important topics subject wise, and also weekly schedule subject wise. You'll find around 12 to 13 videos, right? And rest of the subjects, I swear I'm going to complete them as soon as possible. Viral, my room is changed. Oh, yes. Oh, right. Yeah, we actually shifted. I already told you, right? In one of the live sessions, we shifted our house. I mean, we took a new house in the sense so that I will have a dedicated space for my working area. So this is my dedicated space. I mean, I have my cupboards over there. I have my cam and my board over there. So this is my chair and this is my table. I have a laptop, printer, everything set for me to enjoy my work, right? So my wife helped me enormously to design this room for me. And of course, credit goes to, I mean, as they say, behind every man there is one woman who keeps on pushing him for him to achieve his success, right? So it's like I have one strong woman behind me. It's my mother first, followed by my wife. Of course, both have equal role to play in my life. Yes, viral videos. Yes, I've been working in Elur in St. Joseph Dental College. So I'm staying in Elur now. Right. So anything else, guys? I mean, hope you got some useful valid points in this session, right? So I have already shown you the board, the overview of what I have written on the board, right? So we have discussed that very briefly. If you have any queries, anything else in general, I'd be happy to share. You want me to make live sessions with my wife? Why? Why viral videos? By the way, what's your name? Nidhi, thank you sir. You made this part of studies most enjoyable part of PDS and gathering knowledge too. That's really one of the best compliments I've ever got, Nidhi. Thank you so much for your love. And that's the core of my entire work I have been doing so far. The main objective of why I've been doing all this is, right, it's because I enjoy teaching. And the best and the most important aspect here is I want to enjoy myself during my course of teaching or preparation. At the same time, I want to make the subject easy, make the subject accessible, and make it enjoyable for everyone who is going through it, right? So once you start enjoying, and this Saturday we're going to have a live session on this particular core topic, when passion meets purpose. So once you enjoy what you're doing, the output which we are going to see, it's going to be enormous. It's going to be somewhere high in the sky. So in order to have that kind of quality output, in order to see yourself as a satisfied individual, the best part is to enjoy what you do. That's what even I say in my mails. I keep on saying in my videos or in my recorded versions that we should enjoy what you're doing. If you're not enjoying, it means it's not going into you, right? So you're just doing it mechanical, and there won't be much life in what you're doing, and ultimately there won't be any purpose. And as I say, I mean, you might ask me like, PG preparation, it's all tough, right? So I mean, we have to, I also discussed this in the previous session, we have to wake up early in the morning, or we have to spend a lot of time on studies, we have to understand a lot of information. But the beauty of this, or the positive side of this, is you're trying to have, or you're trying to grab more information than any other person you ever know. So once you're entering into post-graduation, all the information which you are learning now is going to help you enormously. It's going to give you enormous confidence, right? And the rank which you get through entrance, that really gives you a kind of satisfaction that no other materialistic thing would ever give you. That's the reason why I've been striving so hard to make learning, or to make understanding or providing information as enjoyable as possible, right? Viral videos, you are talented or ma'am? Just wanted to know. Of course I'm not, I'm dumb. I'm comparatively dumb. So my wife is more talented, she's more intelligent. That's true. Prithvi, thank you sir. You focused on important topics in each subject, but in important topics in general medicine, some other subjects are specially mentioned all important topics asked in previous exams. Prithvi, all the important topics which I have been mentioning in rest of the videos are also from previous exams only. Maybe I'm not reading out the names of those exams because it's being repeatedly the same, but all the topics which I have been discussing in the important topics subject-wise playlist, they're all from the latest AAPG, APPG, NEET 2013, Common Exam, NBDE. So they're all from the latest exams only, right? It's not just general medicine, but it's all the subjects from the previous exams. So that's the way in which I choose the important topics. Thileli. Yeah. Welcome, Thileli. Glad to hear that. Ramya Kannan. Hi, Ramya. You're most welcome. Right? So it's past 1 hour 20 minutes. I mean, I'm not even knowing the time interacting with you all. So shall we conclude then? Because again, tomorrow morning we're having a live session at 5 o'clock. Let me see how many of you are going to join me tomorrow. So tomorrow and day after tomorrow morning 5 o'clock we're going to have multiple choice question discussion. Tomorrow MCQs discussion. Day after tomorrow, that is on Friday, we're going to have image based questions, exclusively image based questions, right? As I promised previously, I'll dedicate one live session for image based questions every week. Sadhana, yeah. My source of inspiration, frankly speaking, is my students. I don't know how I talk, frankly. My students give me the feedback and the response in itself inspires me a lot. And thank you so much, everyone, for being a source of inspiration. So I feel it's a kind of reciprocation, isn't it? Thank you so much, Sadhana. Prithvi, glad to hear that. You say teaching is very helpful, material which you provide is also very good. Thank you so much. Yeah, glad to hear that, Prithvi. And you know what, at the end of the day, it's this kind of comment, a single line saying that whatever you're teaching, whatever you're giving is useful. That makes my day. And thank you so much for your wonderful comments and for your love and affection. Yes, of course, Sadhana, I feel blessed. Thank you all for your love. See you tomorrow morning at 5 o'clock. If in case you have any queries, you can mail me anytime 24/7, right? All the very best. Take care. And regarding the questions, you no special guest? You want special guest today also? I mean, we have special guest. I locked him outside so that he'll not come and disturb me. I mean, you want him, I can just present you. Yeah, then give me 2 seconds, right? I'll just get him. Here you go. I mean, he has been sleeping actually. So he's just yawning now. So actually he wanted to come inside the room, but I didn't allow him because he's biting all my charging wires and all. So I locked him out. I mean, I locked myself inside the room. So here you go. Sleepy boy just woke up. Say hi to everyone. Say hi. So Megatron, here you go, our Megatron. He's still yawning. Hello, hello, hello. Yes, he's in fact very cute and very soft and sensitive also. You should take extra care of him. I mean, if I allow him to sleep, maybe he'll sleep like this. Chichi. Okay? Right. Yeah. So we'll just conclude, right? Yeah. Right. So good night. Give your best, right? So just relax, chill out. At the same time, make sure that you enjoy your preparation, right? So just take that a single point from this live session apart from the subject which we discussed. Yes, Prithvi. Yeah, definitely. We'll have more image-based questions. Also, we'll have more live sessions. Definitely, Prithvi. I'll definitely consider your suggestion, right? Yeah, you're welcome. Okay, right then. We'll conclude, right? Yeah, bye. Take care. See you tomorrow morning at 5 o'clock. Keep smiling.